I come back to the question that always astounds me, which is we have so balkanized our medical reimbursement system that we can't talk to each other and say, look, across the board globally, all of these new technologies, all these new agents are going to significantly reduce recurrences. They're going to significantly reduce the need for readmission. In the long run, they seem to be cheaper than the older drugs, which per dose look to be cheaper. Why, I'll just say this, why can't we all just get along? What's going on here?
So my experience is that medical directors of insurance companies are pretty reasonable. It takes an extra step, maybe to pick up the phone or write an appeal letter. But if you can make a medical rationale and include some financial information in there, I often am successful with an appeal.
But why should you even have to do that? Why can't somebody sit down at a large table and all the players say, this looks like a good idea?
Well, but you know, I must say, fidaxomicin, as an example, is actually available to many more clinicians in many more situations than they actually use it. And I think it's important to talk about that. You know, actually many payers do pay for fidaxomicin because they do understand that the economics works in their favor, not to mention the fact that they benefit patients. But I think many physicians, you know, it starts with maybe you have to do a prioritization once, or you just know the criteria. They know it's costly to acquire. And so I think it's really important. I think it all starts with physicians. And I think it all starts with the physician's obligation to the patient's benefit. And I think physicians have to ask, what's the best strategy to benefit the patient, and then ask, is it possible to do? And they will discover that many of those strategies to prevent recurrence are actually possible and will benefit their patients tremendously.
Does that make sense? I mean, that's nice, but it sounds like it's putting the physician out there with armor and a helmet and a lance and a steed. And why do docs have to go through this? Why do you have to jump through all these hoops?
We use fidaxomicin in a cost-effective way, and I think we benefit a lot of our patients.
Well, I know that.
And we again and again and again, every year, because we are very, like everyone else, we are very vulnerable to economics, and we find that we can do that in a cost-effective way.
But he's out there writing letters. He's out there sending justifications to a third-tier bureaucrat somewhere to get what you say is the best treatment.
Well, but as I said, again, we don't get a lot of pushback from payers. If you start someone on fidaxomicin, they do fine. They usually agree to continue that. And I think it all starts, if the physician doesn't prescribe it, obviously the patient is not going to get it. And I think that's the very important first step in doing that.
I mean, am I crazy? Am I crazy to think that we can get all of the stakeholders here to agree on one thing easily?
I think you are.
Well, thanks. You know, by the way, you agree with my wife on this. I'm just insane.
Well, I think it's just extremely difficult when you have various economic motivational factors to integrate. And that's why, in some ways, the guideline is trying to move the process in the most favorable direction. But it takes time. It just doesn't happen overnight. I mean, we've gone through 25 years of metronidazole use, thinking it was just as effective without having really the adequate kinds of data to support
I think that's critical. So as Yoav said, my experience is more insurance companies are covering Fidaxo without much pushback, so the insurance companies are catching on to this new drug. But I also think we need to do a better job educating the physician community. So there are multiple studies, including one that we did, showing that physicians are using metronidazole for severe C. diff, which is contrary to the guidelines. But they were brought up that metronidazole is the first drug to use for C. diff. So physicians have so much information to integrate, new information all the time. How can they possibly keep up? I bet if you polled most primary care physicians or hospitalists, not many of them have heard of fidaxomicin.
Well, we're talking to you. We're looking at you out there. Well, you know now what these folks have told you about fidaxomicin, about the fact that metronidazole isn't where you want to be. This is one big step, I would think, toward physician education. But we've got to educate third-party payers, got to educate the government, got to educate pharmacy people to realize that their budget is one small piece of the pie. Although I do have some sympathy for the pharmacy directors because they've got to make a budget. Okay. And the CEO of the hospital says, you're over budget. You know, we'll get a new pharmacy director.
Well, when we did our first study of metronidazole versus vancomycin, this is 3 years after the discovery of C. diff, and vancomycin was already being used heavily for therapy. It was the only identified treatment agent. our pharmacy was complaining to us about the cost of vancomycin was breaking their pharmacy budget. And we did a study of metronidazole for comparison, driven almost exclusively by economic factors, and showed that, you know, a small study, too small to really say they were equivalent, showed that there was at least no difference. But again, the study was too small. But that brought metronidazole into the forefront together with vancomycin. And this happens repeatedly. I mean, you know, it's hard to believe that the argument then was that vancomycin was too expensive compared to metronidazole. Today, it's fidaxomicin is too expensive, but even vancomycin cost acquisition-wise is still high, even though it's generic orally. The generics have priced it very close to the original drug.
You know, I recall when the statins were first introduced.
Sure.
And there were folks taking statins off the formulary because they were very expensive. But folks were saying, look, 5, 10 years down the line, you're going to be paying for these people's bypasses, their cabbages, their MIs, their transplants. And someone came back to me when I made that case and said, but I got to make my next quarter.
Right.
You know, I'm a CFO, and I'm responsible for the budget now. And there was kind of an unspoken addendum to that, which is by the time that cost hits, I'll be gone.
Or they'll
Not
have
my
another
problem.
insurance company that will bear that cost.
Right. So doesn't this sound like we're repeating our history over and over and we're not learning anything?
We do it all the time.
Well, that's no excuse.
And in C. diff, and I not only that I agree with you, but in C. diff, the risk of recurrence is so high that if you can decrease the, you know, what would you do if it was your mom or your spouse that came with you? What are you going to use to treat them? You know, if you have in your right pocket an antibiotic that will give them a 25, 30% recurrence, and in your left pocket one that will cut it by half, what are you going to use? And so I think that in C. diff there's so much to gain by preventing recurrence if you choose the right patients. And that's really the important message. And once you do that in the right patients, the economics will follow, because as you heard, it's highly cost effective in these patient populations. And you should use it up front because that's the way it was studied. As Darrell said, you know, some people use it without data, for example, in very severe C. diff, which actually the new guidelines you know, do not recommend in very severe C. diff. But also, we showed when we studied fidaxomicin is that its best use is when you use it initially in the first episode or second episode. If you allow patients to get into multiple recurrences, you don't even know whether fidaxomicin is going to help.